afternoon session today. So we are honored today to have this fertility track. We have 3 presentations this afternoon. The first will be by Dr. Muhilan. Let me just give a brief introduction on Dr. Muhilan. Dr. Muhilan, he has been practicing medicine for about 20 years plus. So sorry, it makes you look old. And then 15 years of that was actually as a surgeon, urologist, and mental health specialist. And the bulk of his career was with the Ministry of Health in various hospitals and with University Malaysia as a lecturer in surgery and urology. And the last few years has been with Thomson Hospital, Kota Damansara, and TMC Fertility. So during this period, most of his work has been focused on male infertility and men's health treatment. And his basic qualification was from Manipur, India, gotten in 1998, and the rest of his degrees such as FRCS, urology, and others were accumulated along the way from training in Austria, India, and Malaysia, and certification from the urology boards in Malaysia and Royal College of Surgeons and Physicians of Glasgow and the Royal College of Surgeons at Edinburgh. So I think without further ado, let me invite Dr. Muhilan to share with us on his presentation today. Dr. Muhilan, please.
Hi, good afternoon. So my presentations tend to be very, very informal. So anyone wants to ask a question, we are a small crowd, put up your hand, ask, it's fine. Don't let the questions linger. So I'm a urologist and I do a large part of the infertility work in Greater Klang Valley, mainly because our hospital is one of the largest infertility centers around. So in fact, my colleague Dr. Y is here as well, and the fertility sister, and the oncology sister. So today's slides, I actually borrowed a few from my colleagues at the University of Miami. They had prepared some presentations on male infertility related to oncology. So this is the University of Miami team, and they were kind enough to share some of the slides with us. Right? So now, whether we like it or not, cancers are growing. Number of cancers in the younger population is growing. So when this slide was done, this was about 10 years ago, 10% of cancers were below 45 and 1% below 20. I think the statistics have not changed. It's roughly the same percentage, but the volume, the numbers have gone up. So the oncologists have done an amazing job, right? In 1970, half the patients will die, right? Most will not make it. Currently, the oncologists save about 80+% of the patients. The thing about saving that many patients, which is a good thing, is you then have 80+% of patients who, in about 10 years after the cancer treatments, come to the thing about getting married, having kids. So these two are actual Thomson patients that I saw over the years. Both came to us. One got married. He was about 38. He's been married about 3 years, so he came to see us. And basic analysis showed azoospermia, no sperm. So you dig a little bit, he had non-Hodgkin's, and he had chemo and radio. Second guy, bit smarter, he had 27. Now, he actually knew he had cancer. He suspected infertility because of his own reading. He had not been counseled, and he came in for pre-marriage screening. And sadly, his semen samples also showed azoospermia. Now, I actually ended up operating on both these patients, 50-50. The 38-year-old guy has embryos. I don't know yet whether we will transfer the embryos and when his wife will get pregnant. But the point is, we got sperm, fertilized the eggs, and he may get pregnant. His wife may get pregnant, not him. He gets pregnant, it'll be amazing. Okay. The 27-year-old, I explored the testis. Basically, testis was gone. There's nothing much for me to do. Due to religious considerations, he will probably, if he gets married, go for adoption. Right? Okay. Now the problem with this is, a lot of my slide here is going to be talking about prevention. That means they should not reach the stage where I have to operate on them. And that is based on the oncology team, the oncology sister who's sitting over there, and the oncologist who's sitting over there. an oncology surgeon who's sitting over there, right? So if you talk to patients, right, almost all of them want children at some point, more than half, and 70+% of them who don't have children want children. The problem is, most of them, only 2/3 have heard something about preservation of fertility, 2/3, another third have never even heard it, and less than half have anything to do with sperm banking. Sorry, am I going too fast? Can you all hear me? Can? Right, good. Okay. So there is actually Oncology Association guideline that says any fertility patient, any oncology patient, whether male or female, should be offered fertility preservation, right? And this has been around since 2006, so that's about 20 years, more than 20 years. And yet, when we look at the statistics, half the patients have never even heard the term fertility preservation. Okay. Now, interestingly, my oncologist is not bad. He actually talks to the patients about fertility, and patients still reject. That's a different story. You offer patient rejects for whatever reason, that's fine. We have done our best. But not offering it at all, not a good thing. So, now, this is simple, right? You're offering fertility preservation. Quite easy, right? You come, you got cancer, we're going to do something. But as one of my colleagues pointed out, at that time you tell some parent or some mom, and something I hope you guys never have to do, that your child or loved one has cancer. The news is already so horrible that to discuss fertility sucks, right? I mean, you already just told some poor mom that your son has cancer, and now you want to talk about fertility, like too much, all right? But we have to. You don't have to talk about it then. You probably don't start therapy the next day, right? You have a gap, you have a window, but it's something you have to do, because this is going to come back to bite them 10 years down the line. Tell them the good news. 80% of you are going to be alive 5 years from now. And your kid is going to grow up, is going to have children, and then you're going to have a problem. The other thing is, a lot of doctors believe pediatric patients don't have good sperm quality. Wrong. They have excellent sperm quality. We just have to find it. I'll come to that in a second. Third one, oncologists believe that the protocols are excellent. Okay, so this is where statistics lie. Almost all the patients, about a quarter of patients will have permanent azoospermia, but the rest will have OAT. That means you will have subfertility. That means you can have lots and lots of sex, you have some sperm, you're still not going to get babies, right? But using those sperm to do IVF is harder than using preserved sperm. And the fourth point is what I mentioned earlier. At the time of diagnosis, all you're worried about is, are you going to survive? Children come later. So, now what happens if you miss this, right? You may think it's not a big deal. These are the slides, and this one came from Miami actually. So these are siblings, and the two things that we care about as fertility specialists. How many % of patients get pregnant, or their spouse get pregnant, and how many get live birth? You can see the gap difference. So these patients look perfectly healthy, they look perfectly normal, everything looks good, no cancer. Can you see that big gap? Hold on, am I pressing this correctly? Alright, can you see that nice big gap there? That's the gap between a cancer patient and a non-cancer patient, with everything else being equal. And then there's another concern, right? You have undergone chemo, radio, immuno, whatever weird therapy. Sorry, I walked through the conference hall, I couldn't understand half the words that were on the wall. Oncology is stressful. Okay, seriously. Was there increased incidence of birth defects? There wasn't actually. Cancer patients treated properly had the same, roughly the same incidence of birth defects as a normal couple. So there's actually no reason not to offer fertility treatments for patients. So why am I pushing this? One, honestly, if I operate and I find sperm for you, it is expensive. Right? It is really, really expensive. And insurance is not going to cover this. So just by default, a lot of patients can't afford it. preserve the sperm will cost you 600 ringgit a month. That's it. 600 ringgit a year to preserve sperm. That's it. All you gotta do is collect some sperm. I'll tell you guys how to collect sperm. It's not difficult, right? I'm sure a lot of you are experts, but we'll go through this later. Okay. Even patients with low sperm counts or azoospermia, the tissue that we collect, not difficult, we can collect and freeze. And the tissue that we can collect can serve in our new cryopreservation tanks 30 years, not a problem, right? That's almost the entire fertile life. Doing ART with preserved sperm, 50 to 80%, 50 to 90% of couples will have babies. That's a lot of babies. And only 1 out of 10, or 1.5 out of 10, eventually get rid of the samples without using it. You see, if you have it, your wife gets pregnant naturally, good, throw away the sample. Save 600 ringgit a year. So, your fertility patients, the young ones, will fall into 3 categories. You got the older kids, that's your teenagers, your 13, 14, 15, depending. They produce sperm and they have learned to masturbate or ejaculate. Easy. Show some porn, collect some ejaculate, freeze. $1,000 for the first year, $600 after that. Easy to do. Almost every fertility center in Malaysia will offer this service. HKL has started offering the service, but on a very limited scale. Okay, but you can actually do it. It's not difficult at all. Second group. Okay, this one is a bit more challenging. So you got 11, 12. You suspect there is sperm. They're going through puberty, but they haven't got around to the fun part of watching porn and ejaculating it. So now they don't know how to ejaculate, and it'll be incredibly embarrassing to explain to them how to masturbate. Short version, electroejaculation. So it's a small device. You stimulate the bottom of the penis around the prostatic area, and they will ejaculate. And you get quite a lot of samples. So those two are easy. Electroejaculation, normal ejaculation, collect, freeze as well. Okay, third group is the challenge, right? They're not producing sperm. Now, any child, regardless of age, you are going to find some amount of spermatogonia. Those are precursor cells. They haven't matured enough to produce sperm. We still collect small incision, small surgery, do it under GA, collect a few samples, and we freeze. Some labs in animal studies already done, and I will introduce you to Brady at the end. And Brady is interesting. I'll show you all Brady. So basically, once we have some amount of tissue, there is a theoretical possibility we can use that to get sperm cells and do IVF. Okay, so it's actually been done. Like I said, I'll introduce you all to Brady in a second. Okay, so this is basically a relook at that. The two things that were not mentioned. Long-term cost, cryo is not cheap. Okay, it is cheap, like 600 ringgit a year, but for me that could be cheap. For other people it could be expensive. If you got 5 other kids you got to pay for, right? Ethical considerations. Almost 2/3 of your patients are below the age of consent. How you want to explain this to parents to collect tissue that can be used to get pregnancy, and how you're going to handle that tissue is a delicate minefield that you will need to talk to parents about carefully. All right? Like I said, they're already traumatized by the diagnosis of cancer. This was, again, something I mentioned earlier, and just to show you the slides. So, older patients, teenagers, almost 100% we get the sperm. Younger patients, as long as they do have some sperm in the testis, we can get sperm most of the time, 2/3. And those who are below puberty, still 50% we can operate and get some form of spermatids or spermatogonia, which we freeze. So that's pretty good rates. Okay, hold on. Okay, sorry, this is a repeat of the last slide. I think I jumped to it. Okay, let's talk about cancer itself. Okay, this is important because at the time of your diagnosis of cancer, right, the cancer itself has already started affecting fertility. So a lot of your semen samples, not so great, right? Honestly, they're not going to be so great because some of the cancers disrupt your hypothalamic pituitary axis. Some patients are coming with loss of weight, disruption of the lymphatics, malnutrition, low-grade fever. All these things wipe out sperm. All they cause sperm numbers to drop, sperm quality to drop, and sperm motility to drop. Right? So even before the oncologists get their hands on them, sorry I'm blaming you for this, the cancer itself already drops sperm quality. And I'm not an oncologist, I'm not a gynae. Does it do the same for the gynae as well? Yep, okay. So before even we treat the patient, the cancer reduces fertility. Once we start the treatment, it gets worse. So radiotherapy, even with shielding, even if you do it fractionated, depending on where you're doing it, you will still wipe out spermatogonia, number one. And it takes about 2 years to recover. And hypothalamic pituitary axis disruption takes about 6 months to a year, if you're lucky, to come back. Yes? Okay. Depending on, so this is an interesting slide. So if you look at it, the first two, it says very high chance the patient is going to have azoospermia, no sperm. That's true. The problem with it is all the rest where it says low, temporary, and intermediate, those patients will have OAT. OAT is oligo, low numbers, asteno, weak sperm, teratospermia, abnormal sperm. So even though they do recover and the effect is temporary, the sperm parameters still suck. Getting pregnant, still a challenge. If you have pre-treatment samples, even better. So for those who slept through first year of medical school, which includes me, sadly, the first one at 4 weeks, there can you see it just shows the slide 4 weeks. Those are your precursor cells, spermatogonia. Now just a quick one. In your testes, you got two. You got you got Leydig cells and Sertoli cells. Leydig cells produce testosterone and they are very resilient. It takes a lot to kill them. They make up about 25% of testicular volume. Sertoli cells make up 75% of testicular volume. Your chemotherapy, radiotherapy hits the Sertoli cells. So your testes will go from that big to that big. And that loss of volume is Sertoli cells. Right? So you wipe out those three. So when we do surgery at those prepubertal children, those are the cells we are preserving or we try to take out. Okay? All the rest will die. We want the spermatogonia. Now, how do we get those cells out? The ones I just showed you. This is, so I'm going to promote Thompson here. That's Thompson's lab. That's my lab, right? So we do a lot. We do a lot of fertility work. Now, if I operate on your pre or post chemotherapy patients, pre is usually those who you can't get sperm any other way. You can't ejaculate, can't do electroejaculation. Or post is because they have shrunken, small, non-obstructive azoospermia. This is what we do. We do micro TC. And I'm successful about, sadly, only about half the time, right? Max 60%, usually about 50%. Okay, I'm up to 3 minutes, so let me run this by. So, what happens post chemotherapy? I do micro TC and pregnancy rates. Pregnancy rates, end of the day, it's a 50-50-50 number. We fertilize half, and of those we fertilize, half will have live births. So not too bad. We still can salvage your post chemotherapy patients. Okay. Remember I told you we find those cells in the pre-pubertal children. The spermatogonia is little cells, right? So we do a biopsy, we freeze it, we grow it, and if we get sperm from that, we do IVF, ICSI, and we get a baby. And that brings us to the star, Grady. Sorry, not Brady, Grady. So Grady was born in 2018. So what they did was they operated on testis, they removed testicular tissue, and then they put it back on Grady, on the scrotum and the back. Okay, so if you see it here, can you see that, the center slide? All those little red dots are where we put back the testicular tissue. And after 9 months, when we looked at slide C here, and we took those tissue and we opened it up, you actually had sperm. Alright, and they then passed it to whichever unfortunate embryologist this was who had to do this. and they did ICSI, and a few months later, you have a baby rhesus monkey. Okay? As far as I know, that's the first and last. Then they ran into ethical problems and about pushing this to humans, because now we know we can do it. It's just whether we should do it, and this is a political problem. Once the politics are sorted out, we can do it. So collect the tissue, freeze it, let the politicians sort it out whether we should do this or not. But you have those young children, they are going to need that tissue in 30 years. Hopefully the politicians have sorted this out in 30 years. Whether we can do it. It's whether we should do it and we are allowed to do it. Stem cells. Okay. In Malaysia, there are a lot of people promoting stem cells. Price range 50 to 150,000 per shot. Either systemic, where you inject it in, or whether you inject it into the testis. At this moment, as of 2022, there are about 130 to 140 clinical trials worldwide. None of them have been tested out to maturity in humans. None of them have produced babies. None of them have actually got viable sperm out from a zero. That means you have a biopsy shows totally nothing to any form of sperm. So far, zero. And I think that number holds even for female infertility. What's your best chance? And this is my message for all the oncologists, oncology nurses, sisters. Get a program. Get a formalized fertility preservation program. That is your best chance for preserving fertility in children. And this is an original article from the University of Miami. So you can see, up to 2016, they had a 3% preservation of fertility. When they put the program in the 1 year that they had the program in 2016, when this article was presented, their fertility preservation jumped from 3% to almost 20%. That's quite good, right? That's a lot of fathers. So, short message. Cancer survivors in the future want to be parents. We all do. Cancer is going to affect fertility. The treatment is going to affect fertility. It sucks to discuss with a parent or someone you just told has cancer that you want to talk about the future, since you don't even know if they have a future, but you have to do it. Your best chance is still cryopreservation. If you fail, yes, we can do some really exotic surgeries to get it done. One of it we're already doing, micro-TC. Transfer of spermatogonia and using cells harvested for that for ICSI, ethical treatment has not been allowed anywhere yet. So that's a political question that we have to answer. Right? I think that's my last slide. So thank you for being a great audience, and for any questions, I'll answer at the end.